Okay, well, thanks for joining me this morning. As Kayla mentioned, I'm Daniel. I'm one of the third-year residents here in our program. I'm going to get this morning started off talking to you guys about ASCVD risk and lipids. Oh, okay, no disclosures. So my objectives for this morning are number one, for us to be able to recall ASCVD risk assessment in the lens of the 2018 ACC AHA guidelines, describe indications to start lipid-lowering therapy, for us to appreciate when to use coronary artery calcium scoring, also known as CAC scoring, counsel patients on statin efficacy and adverse effects, and gain some familiarity with non-statin therapies, which are becoming very exciting lately. So I won't go into in depth on the epi of cardiovascular disease, which we all know continues to be the leading cause of death in the US. It accounts for 20% per year. Every year, there are about 800,000 ACS events, 200,000 of them actually being recurrent events. And this doesn't include what we think of with ASCVD, which per the guidelines actually expands to not include the ACS, coronary disease, but also patients with stroke, TIAs, peripheral artery disease. So there's much more involved here. And despite advancements in treatment, prevention is still challenging because of all the multifactorial contributions to an elevated ASCVD risk. I'm sure, as you guys have probably noticed over our short careers in medicine so far, that patients are just getting sicker and sicker. But for these reasons, it's important for us that we regularly think about who should engage in risk assessment and what we can do about it. So for the longest time, there was just statins and aspirin for us to think about therapies that we could offer. But now there are new things that we can do and actually new ways that we can risk stratify patients. So you guys have probably seen this before. This is the ACC AHA risk calculator. And this is a very common way that we assess a person's risk of ASCVD. So this calculator was introduced back in 2013 with the guidelines, and it was updated again in 2018, I believe. Before then, we actually commonly used the Framingham risk score, but this calculator expanded to not only include cardiovascular outcomes, but also to include fatal and non-fatal strokes. You guys have probably been exposed to other calculators out there. This one is commonly used primarily because it's based off of primarily US cohorts. But there are many of them out there. All of them have the risks and the benefits. But this is one that we commonly use and will be the focus of today's talk. This figure may also look familiar to many of you, and it's found in the 2018 guidelines. It provides an algorithm on how we assess ASCVD risk and decide on who may benefit from statin therapy. And we'll dive into each individual part of this figure in the next few slides. So this first section, that includes patients we know will benefit from statin therapy, and it's often regardless of their ASCVD risk score. So first of all, at the very top, this includes patients with hypercholesterolemia, defined as an LDL greater than 190, and they warrant a high-intensity statin. For this group, I want to call out that there's often a genetic cause of their hyperlipidemia, such as FH. And so for these patients, when I have an LDL greater than 190, I make an extra effort to get a strong family history. In addition, though, I want to point out that we should always consider secondary causes of elevated lipids, primarily through medications and thyroid disorders. The next group includes patients with diabetes. These patients above the age of 40 and actually have an LDL greater than 70, and they warrant a moderate intensity statin. And oftentimes, I feel like I'm tempted to start a patient on a statin when they have diabetes, age 40, all that, and not really feel inclined to check a statin again, check lipids again. But actually, patients with diabetes and ASCVD risk greater than 20%, they should be on a high intensity statin as well. So maybe it may be good to check once in a while. But also, patients with diabetes with evidence of end organ dysfunction, such as retinopathy, kidney disease, neuropathy, they should be on a high intensity statin as well. But after thinking about those initial groups, we bring it back to the calculator and we start thinking about age. Remember that the ASCVD risk calculator was specifically derived from cohorts between the ages of 40 and 75. But you might notice actually when you're in the calculator that you can actually start to enter ages starting at 20 to determine something called lifetime risk. There's actually a study just published last month, I believe, that specifically looked into this. And they followed patients between the ages of 20 and 39 over 10 years. And they found that they looked at long-term and short-term risk. And they defined long-term risk as greater than 20%. They found that patients with low short-term but high long-term risk had 5 times more ASCVD events than patients in this population with both low short-term and low long-term risk. At the same time, I think there are ongoing studies on how we assess risk in patients above the age of 75. Now, this is a little controversial because now we're starting to think about statins or lipid-lowering therapy or risk across the lifespan. But this is something I would keep an eye out for the next few years as we start to learn more. This is still an evolving area. And so today my focus is going to be really on that age group between the ages of 40 and 75. Okay. So assume now that our patient is of appropriate age to calculate a 10-year risk score. With the 2018 guidelines came actually new categories. We actually now have the borderline risk category. So patients between, or patients with a 10-year risk of 5 to 7.5%, and those with an intermediate risk between 7.5 and 20%. And so while generally speaking, patients with an intermediate risk warrant a statin, these guidelines encourage us to consider risk enhancers to make these decisions with our patients, especially those in the borderline risk group. And for me, also those who are iffy on starting a new medication. And we'll get into these risk enhancers in a couple slides. So to summarize, who do we start on a statin or who do we consider for lipid-lowering therapy? Number one, patients with an LDL greater than 190, patients with diabetes over the age of 40, those with an ASCVD risk score greater than 20%. And then finally, that large bucket of patients after we discuss risks and benefits of them, and we favor starting statin therapy. So I'll pause there real quick. Kayla, do we have any questions? I can't see from my view.
Nothing in the chat so far.
Cool, pretty straightforward. So what are risk enhancing factors? There's a lot on this slide. This list is not exhaustive, but these are some of the big ones. Number one, family history of premature ASCVD. So remember, this is first degree family members defined as males less than age 55 with ASCVD and females less than age 65. Number two, we have primary hypercholesterolemia. This is defined as patients with LDLs persistently above the 160 range, or even triglycerides above 175. This is important because just because someone doesn't have an LDL of 190, it doesn't mean they might not warrant a statin. There's this idea that we should think about lipids similar to smoking, in which someone can have a 35 pack year smoking history. The same applies to lipids as well. And patients with high cholesterol over a long period of time certainly are of elevated risk. Then we have inflammatory conditions, primarily chronic kidney disease, but also HIV, rheumatoid arthritis, lupus. And I think the explanation is pretty self-explanatory that the inflammatory component is a huge part of atherogenesis. Then we have two categories actually that were added, I think, in the 2018 guidelines, and that includes premature menopause, age less than 40, and then high-risk OB conditions defined as preeclampsia, gestational diabetes, preterm deliveries, things like that. But then when clinical history still leaves us questioning whether statin therapy is indicated, we actually now have adjuvant laboratory markers and imaging that can be helpful. So the first one is advanced lipoprotein testing. What this is that this fractionates lipoproteins by particle size and density. A broad generalization is that patients of the same LDL, though of smaller particle size, are more atherogenic than patients with larger LDL. You won't see these assays very often, and the reason is because they're not commonly used because they're not helpful in reclassifying or redefining what person's risk may be. And so as a result, they're less actionable. But nevertheless, you still might see some patients roll into clinic with these results. Then we have high sensitivity CRP, which we all know is a non-specific marker of inflammation. Clinically, I haven't seen this very often as well. The most often setting that I see them in actually is in clinical trials and trying to assess the benefit of new lipid lowering therapy. So I won't get into it. Then we have apolipoprotein B. What I will say about this is that it is thought to be the highly atherogenic component of lipoproteins, particularly LDL and VLDL. Situations that I've seen this in is when we believe patients should still have residual risk despite their LDL being at goal. The next one is lipoprotein a, which has gained a lot of buzz lately, and I'll get into that the next slide, as well as coronary artery calcium scores, which I'll dive into in the next section as well. So you might look at this list and like me, you realize that many of your patients have risk enhancing factors. And so who do you obtain additional testing on? And for me, at least, I do it for patients with a strong family history of premature ASCVD, secondary prevention when there still is a concern for residual risk or recurrent ASCVD events, as a decision-making tool when a patient, when there's some equipoise on when to start a statin. And then finally, when we're considering referring to lipid clinic for various reasons.
Daniel, before we move on, we do have one question in the chat that harkens back to a previous slide. Tini's asking, I don't think I could list medications off the top of my head that cause dyslipidemia other than antipsychotics. Are there more common general drug?
Yeah, so that's a big one, antipsychotics. The other big category that I think of also include HIV medications like protease inhibitors. But I admit I do have to do a quick search whenever I run into this situation. Good question. All right, lipoprotein a. So what is this? This is an LDL particle with an attached apolipoprotein A that is thought to be highly atherogenic. It's strongly inherited. Levels remain stable throughout a lifetime, actually regardless of someone's lifestyle modifications, and it's not actually lowered by statin therapy. So there is this huge unmet need of patients that might not be receiving any benefit from statins. The thing about lipoprotein A right now, at least, and one reason that I don't check it routinely is because there's not anything we can do about it yet. There are therapies coming out, such as pelacarsen, in which we're still waiting on outcome data. And once these are out, they might make it more actionable. It might make this a more actionable marker to obtain. There are some situations where it might be warranted though, and it's similar to the previous slide. I will say that European guidelines, which tend to be a little bit more aggressive on lipids, they actually recommend we check once in all adults, given its strong genetic component. But also worth considering in patients with a strong family history of ASCVD or FH, history of premature coronary disease in the patient themselves. Identify patients at risk of progressive valvular aortic stenosis, which is found to have a strong association with this. And then to identify a cause for less than expected LDL lowering on statins. So depending on where your continuity clinic is at, or what your exposure has been so far, many of you have likely come across coronary artery calcium scores. So essentially, these are non-gated contrast CT scans, which means the images are timed to be obtained between cardiac cycles. And the degree of calcium is reported as an Agatston score, ranging from a score of 0 to 1,000. As you can see here, 0, no identifiable disease. 1 to 99 is mild, 100 to 399 moderate, and so on. I also want to point out, though, while I'm on this slide, the incidental finding of calcium on non-gated CT scans, which can actually be kind of helpful. And what I mean by that is those standard non-CT scans that we might instantly find on a patient who's gone to the emergency room or was hospitalized. So radiology guidelines actually currently recommend for at least a qualitative interpretation of coronary artery calcium on all CT scans of the chest. So if you see a report of moderate or severe calcifications, this actually generally correlates with a CAC score of greater than 100, in which many people actually would say warrants a statin. So what I do actually do is I dig through the chart a lot to look for these scans to avoid ordering a calcium score. And this actually came up yesterday for me in a patient who was of borderline risk, who had a CT scan done last year, and we found that there was moderate calcifications, and so that helped tipped us over the edge to think about starting a statin and save them a few $100 from ordering a CAC score. As you can see here, even a mildly elevated CAC score is associated with elevated risk compared with a 0 score. This figure is from the MESA study, 6,700 patients. You can see that CAC scores stratify both for major coronary events on the top figure, which includes MI and death, and MACE in the bottom figure. But what I really want to focus on is the concept of the power of 0, as this is a very important concept when using CAC scores because of its use as a decision aid. So you can see on the left figure that a CAC score of 0 has a very good 10-year all-cause mortality survival rate, so it's the top line. On the right, you can see that a CAC score of 0 compared to other cardiovascular biomarkers, which actually includes lipoprotein (a), is very good as well. So because CAC scores of 0 stratify risk extremely well, they're often used on deciding who should not need a statin, despite being of borderline or intermediate risk. So for me, patients who I think would benefit from a CAC score because I'm looking for a power of 0 or score of 0 are patients who are reluctant to initiate statin therapy and want to visualize on a scan the risk of coronary disease. Number 2, patients concerned about the need to restart a statin after having a side effect. Older patients, typically men aged 55 to 80 who don't have any risk factors and their ASCVD risk calculator is purely driven by age. And then borderline risk patients with risk factors that increase risk but may not require a statin yet. One thing I find important to think about is at what age should I expect a CAC score to become greater than 0 or non-zero? So I found this figure helpful because you can see here that in the absence of risk factors, women are expected to convert to a non-zero CAC score in their late 50s, whereas men in their early 40s. And then you can see that age get lower with additional risk factors. That being said, there shouldn't be an age cutoff. This is just a helpful tool for us to anticipate what to expect when we order a CAC score with the objective of hoping for a score of 0 and not starting a statin. CAC scores up to 10. Question from John Cho. CAC scores up to 10, while not as good as 0, seem to track well out to 15 years, relatively speaking. Yeah, CAC scores risk stratify very well. And so even differences between 0 to 100, 100 to 200 actually do help predict risk quite well. But say you do have a patient with a CAC score 0. I think a lot of us often ask this question, how long is it good for? What is the warranty period? So it seems like a warranty period of about 5 years is reasonable for a CAC score of 0. And for scores that are non-zero, greater than 0, perhaps 3 to 5 years. I always want to say that there is a caveat. Number one, first of all, not all plaques in their composition are calcified, and therefore they will not be picked up on a CAC score. And so clinical judgment should always supersede any CAC score. And then number two, because of how sick patients are getting, risk factors are always changing. And so if you find someone has other risk factors and judgment would start a statin, then I certainly would do that as well. So as I was saying, some feel that CAC scores are fantastic as at assessing risk because you're actually able to visualize the burden of disease and have a more direct measure compared to other risk calculators, which only try to predict or approximate. So while the ACC and AHA have not published these guidelines, there are some common recommendations on what to do when you get a positive CAC score. You can see here that some would classify a CAC score of greater than 100 as having enough coronary disease to warrant even an aspirin. But I will not open that can of worms today, merely to show that there's increasing thought on how we can use this to stratify patients. Question from Adrian, is the disease we see on CAC intraluminal or extraluminal or both? It's primarily intraluminal. So in summary, a CAC score can be a powerful tool to reclassify a patient's risk of disease. It is particularly useful in patients with, number one, borderline or intermediate risk. Number two, no clinical ASCVD. Number three, asymptomatic, of course. Number four, patients between the ages of 40 and 75 with clinical or patient equipoise. So we can see here that in these categories, a CAC score is great at what we call reclassifying risk either up or down. After all that, let's say we've decided to start our patient on a statin. As a brief review, statins are competitive inhibitors of HMG-CoA reductase, the rate-limiting step in cholesterol biosynthesis. What happens is a reduction in intrahepatic cholesterol leads to an increase in LDL receptor turnover, and then more circulating LDL is brought back into the cells and not in circulation. So now that we've decided to treat, what are we targeting? I wanted to include a brief review of the lipid panel that we often see when we obtain these from patients. The pathogenesis of atherosclerosis is quite complicated. And while there are more lipids involved, the primary endpoint that we always look for, as you guys know, is LDL. But I want to point out that triglycerides are also commonly felt to be the forgotten lipid. And I'm not helping by not really talking about it today, primarily because there's not too much in terms of pharmacotherapy at this point. There is some buzz now, actually FDA approval for something called icosapent ethyl, but still not too much that we do in these settings. Non-HDL has actually been heavily studied as perhaps a more complete marker of atherogenic lipoproteins. Sometimes actually I've heard from lipidologists that you can use a patient's elevated non-HDL cholesterol as a clue to potentially be a surrogate of elevated apolipoprotein B and maybe at higher risk. And then last we have is the cholesterol HDL ratio, which for me, I've had a lot of patients ask about. So it's pretty self-explanatory. It's a ratio of total cholesterol to HDL, and was based on the idea that maybe a higher cholesterol or higher HDL is better. Unfortunately, there have been trials that have tried to elevate HDL and have found that it did not improve outcomes. Regardless, most healthcare providers want the ratio to be below 5 to 1. or 3.5 to 1. A question from Tom. Do you know how the insurance patient cost landscape looks like for advanced testing? Great question. For example, lipoprotein (a). I don't know. I often do see it, from patients coming from the east side. What I will say is that at least for CAC scores, those used to be a few $100s, but those have now started to make it into the guidelines. And I have heard that it's been a lot easier to get coverage for patients for those reasons. So extrapolating from that, at least, lipoprotein (a) at least isn't currently in our guidelines in the US. So for those reasons, I don't know how well they're covered. I'll defer to anyone who has had more experience sending them out. Another question, most of these measurements are based on retrospective cohort data. Are there prospective data that show that intervening based on these different measurements bends outcomes that we care about, like MI? Yeah, that's a good question. So that's primarily, and I imagine we're talking about the other biomarkers, and that's primarily the endpoint of the new pharmacotherapy trials that are coming out, particularly when it comes to PCSK9 inhibitors, which do lower lipoprotein (a), as well as pelacarsen, which I was mentioning before. So that is correct. Outcomes, not too sure yet until another few years. As a review, here's a slide on statin intensity. So frankly, there aren't a lot of indications for low intensity statin. And often we start with something like a Torva or Rasuva. So I just want to highlight this because it makes me pause sometimes when I see a patient who's been on Simva or Pravastatin, and I question whether or not there is an adverse effect in the past. As I'll get into next, it might be worth transitioning them to a higher intensity statin if we still think that there's residual risk. This figure is found on UpToDate that I have seen referred to a lot in clinic that compares the efficacy of statin drugs. So you can see here that you get more bang for your buck when increasing the dose of a statin such as Rasuva and Atorva compared to others. I'm just trying to make a pitch here that really should always be starting a patient on one of those two medications. Personally, I've heard that rosuvastatin also increases HDL as well and less likely to cause muscle-associated symptoms. And so typically, I always start with Rasuva as well. But the point of this slide is, say you have a patient that might already be on simvastatin for unknown reasons in the past, and you're wondering, hey, their risk is still elevated. I need to get their LDL a little bit lower, and they're already at 40 milligrams. Well, increasing them to 80, you might not get as much benefit. So for those reasons, maybe switching them to Atorva or Rasuva may be beneficial. All right, let's kick things off. There's a growing trend to try and move away from the term statin intolerance and more towards something called statin-associated muscle symptoms, or STAMS. Recall that myalgia is more likely to be a statin associated with its bilateral proximal muscles, onset within weeks to months after initiating a statin, and resolves after discontinuation, of course. Patients who are, there are predisposing factors: elevated age, female sex, low BMI, comorbidities such as renal liver disease as well. And I want to point out that highly hydrophilic statins are less likely to cause these symptoms, such as Rasuva and also Pravastatin as well. Lipophilic statins, on the other hand, are more likely to cause myopathy. And this includes Simva, Fluvastatin, and Atorva. But how do we manage when we do suspect that a patient does have statin-associated muscle symptoms? There are a few strategies. first of all, the main one includes discontinuing the statins until symptoms improve, followed by a re-challenge with a reduced dose or an alternative agent. And we often find that even patients who get onto a reduced dose, you can still actually end up retitrating them up back to the original dose without symptoms. They can also try alternative statin regimens, which includes alternative daily dosing with longer half-life statins, again, Rasuva and Atorva, or just reducing the dose. So there was a trial that came out in 2021 called the Samson trial of patients who discontinued statin due to side effects. They found that 90% of the adverse symptom effects were experienced with drug therapy and be attributed to what is seen as a nocebo effect. I want to emphasize that we need to validate that what patients experience is real. What this study does for me, though, is that it enforces that the risk is low. And so I am more willing to engage in discussing switching a patient over to a higher intensity statin if or just continuing to push for statin if they've associated symptoms in the past. This last fall, this piece was published in the New York Times, highlighting some buzz that we've heard about statins increasing the risk of diabetes. Our own Dr. Subramanian, who you'll work with if you do the metabolic elective, was actually interviewed in this article. So ultimately, the answer is yes, but it depends. It ultimately depends on who the patient is. It is more frequently thought to increase the risk of diabetes in patients who already have risk factors, such as an elevated BMI, elevated fasting blood glucose, metabolic syndrome, or in the pre-diabetic range. But what she also points out is that, it often may tip someone over from the pre-diabetes diabetes range, A1C of 6 to 6.5, but less so someone with an A1C of 6 to 9, for example. And so the benefits of a statin still really seem to exceed the risks. I feel like this was the hardest slide in this presentation. Because we often are asked in clinic when we check a lipid, well, what are you looking for and what are you going to do with the data? First, response to statins can be monitored after every dose change or new start after 4 to 12 weeks. And what we're looking for is pretty straightforward with secondary prevention, I'll say. Patients with a history of ASCVD, we target an LDL of less than 70. And actually, as of last year, guidelines suggest that we should target a lower goal of less than 55 in patients with multiple ASCVD events or one major ASCVD event and multiple high-risk conditions. But then for primary prevention, this is where it gets hard. What the 2018 guidelines do say is that patients who are started on a high-intensity statin, you should expect a 50% reduction in their LDL. In patients who are started on a moderate intensity statin, you should expect anywhere from a 30 to 49% reduction. But as you guys have probably seen in clinic, that is so hard to know, so hard to measure when they're starting a statin, especially if there's concerns about adherence or patients are not sure. And also, hey, what if a patient's LDL is at baseline 120? And their ASCVD risk is primarily based off of their age? Do we target an LDL of 60? And that's not an easy answer. And when I actually asked Dr. Subramanian, it goes back to the core concept of what the guidelines suggest, and that it's a risk factor discussion. Patients with elevated risk factors, I think it's reasonable actually for patients on a high intensity statin, maybe to target around 70. Patients with a moderate intensity statin, so patients in that bucket, targeting something like less than 100. What I will say though, is I want to recognize the challenge in primary care's approach to statin therapy, as well as those from the cardiology and lipidology perspective. From my experience in internal medicine as a primary care doctor, man, there are just a lot of things that we're working on with these patients: cirrhosis, liver disease, or kidney disease, and all these things. And sometimes primary prevention kind of falls on the back burner. And the benefit of really being aggressive about these things sometimes gets forgotten. We often can more likely take the bigger picture into play. So I just want to call out that even though maybe some may think that this might be too aggressive of an approach, which I want to recognize. Yeah, question from Maya. Do we know what is the mechanism in which statin increase the risk of diabetes? Yeah, I asked that question too, and unknown. Do certain statins increase the risk more than others? That's a good question. I don't know that either. But I have heard, no, actually, I don't know the answer to that. For those with a strong FH or of dyslipidemia or concern for genetic dyslipidemia, do these targets change at all? Thanks, Jed. That's a great question. One of the few things that guidelines actually are a little bit more clear on is that patients with strong family history, FH, we actually want to target an LDL of less than 100. All right, so the rise of non-statin therapies have led to the publication of 2022 ACC expert consensus pathways for these new therapies. I won't dive into all of them in depth as much as I would like to, but I wanted to have an introductory slide for us to get some exposure to. The first one is ezetimibe, or Zetia. What it does is reduces cholesterol absorption in the small intestine. For monotherapy, so for patients who have statin-associated muscle symptoms or intolerance or adverse effects, you can actually expect an 18% reduction in LDL. And for Zetia on a backbone of a statin, you can expect a reduction of 25%. Adverse effects we see are more commonly a diarrhea and abdominal pain. The outcome trial for this was in Prove It back in 2015. The next non-statin therapy is bempedoic acid, which I know many of you guys are probably eagerly waiting for the outcome trial for, which came out this past weekend at ACC. The mechanism inhibits cholesterol synthesis in the liver upstream of HMG-CoA reductase, so upstream of statin. It decreases LDL by about 17–18%. Some adverse effects include increasing uric acid level and tendon rupture. So yeah, the outcome trial was, the outcome data was actually just announced this past week, and I haven't had a chance to dive into it yet. Then we get into PCSK9 inhibitors, which starts off with the monoclonal antibodies, which bind to the PCSK9, which increases the number of LDL receptors available to clear circulating LDL. Very potent in reducing LDL. For alirocumab, about 58%. For evolocumab, about 64%. And as I mentioned before, it actually also does reduce lipoprotein (a) by about 15–20%. Adverse effects, injection site reactions, URIs, myalgias, and the outcome trials came out a few years ago, 4-year in 2017, and Odyssey outcomes in 2018. And then finally, we have inclisiran, which is a siRNA inhibitor. It's actually administered every 6 months, so it's really nice. It is expected to reduce LDL by about 50%, adverse effects being similar to alirocumab and evolocumab with injection site reactions and myalgias and URIs. And the outcome data, unfortunately, is not out yet and will be a few years in 2026 and 2027. So hopefully this is a good introduction to non-statin therapies. I think that as primary care doctors, there should be a little bit more comfort, maybe in the next few years, maybe now, on starting patients on Zetia and soon bempedoic acid. Zetia, when we're trying to get that extra push for secondary prevention, maybe sometimes primary prevention, and then bempedoic acid in patients who have statin-associated muscle effects, because bempedoic acid actually is activated intrinsically in the liver and not in the muscles. And so you do not have these myalgias associated with it. Question from Leah. Do you have any thoughts on CoQ10? Not really. I've seen it in patients every once in a while. Some have it, some don't, some have benefit. I think it's worth a trial. I'm actually not familiar with the data on CoQ10 though. Thanks for asking. All right, so take home points. Number one, consider risk enhancers when engaging in ASCVD risk discussions with patients with borderline or intermediate risk. Number two, CAC scores can be useful for risk reclassification. Number three, statins vary in their efficacy and adverse risk profile. And so work with patients when you suspect they have SAMs. And then when faced with statin intolerance or LDLs above goal, many non-statin therapies are emerging. These are my references. Thanks for your time. Any questions? Questions from Elena. Any techniques that help get people on statins when they're hesitant at first? I guess it depends on why they're hesitant, right? You know, is the question that are they not understanding what the benefit is? Because as we know, it's prevention, and so the benefits are long-term. So in these settings, you know, do they benefit from a more visual idea of their burden, and is a CAC score helpful? One thing that I've heard recommended a lot of times in patients who might be a little bit hesitant is just start low and go slow. So start on a lower intensity statin, even though it might not be what is indicated from at the time, and slowly up titrate over the course of months at a time.
Awesome. Well, thank you so much, Daniel. I think this was a fantastic talk, as we can see in the comments. Before we break, I'm gonna give Aya just a moment here to make a plug about next week's academic half day that's gonna be put on by RDC. So Aya, go ahead. We're not hearing you, my dear.
Better?
Got it.
Okay. I'm sorry, one of my headphones works, the other one does not. So, okay, never mind. So Aya with RDC, I just want to give you all a nod about the RDC community tour that's happening next academic half day. If you have not signed up, just find the link. I'm putting it right now in the chat. Very easy, 2 clicks, maybe 3 clicks to get yourself signed in and the place you want to go to. We're just looking to have you all with us. If anyone have any questions, just send it for me in the chat or email us, Celia, Will, and I. We're looking forward to have you all there. Link is in the chat.
Perfect, thank you. All right, folks, we are going to take a break now. So take this time, coffee, bathroom break, sign up if you haven't for a slot for next week's academic half day, and we will get back together at 9:55 for our house staff meeting with Ken.
Hey, Kayla.
Hello.
Would there be time to practice getting my slides up after Ken's talk?
There should be, yes, but if you would like to try that now as well, you're welcome to, whatever works best for you.
Okay, maybe I'll try it now if that's okay with you.
Yeah, no, go ahead.
I emailed you back up just in case, but
I saw that. That's always a good idea. Thank you.
Is that working, Kayla?
Yeah, it looks like we maybe are a little bit cut off. So I'm seeing your screen right now on like edit view, not on presenter view.
How do you stop sharing? And oh, here we go. Stop sharing. Okay, let's try that one more time. Do you have tips on how to make it work in the presenter mode?
Yeah, are you doing presenter mode for your?
I'm hoping to, if possible.
Yeah, go ahead and give it a try again.
Okay.
Okay,
Mm,
that
that works.
looks beautiful.
Okay, but then I can't see my notes. Let's. Okay. I looked this up and I practiced, but it's so different in the real.
It always is. That's why we take time to get it set up ahead of time.
Okay. I see John Cho there. John, do you have recommendations on how you make the presenter mode look okay?
Yeah, sorry, I'm on an elliptical machine, and that's why I'm bouncing up and down. Yes, that screen that you were just at that had the presenter view with your notes on the bottom.
Yeah.
Before you open and share screen, on the bottom where it says share screen, there's something that should give you advanced options. Okay,